Today I have with me the president of the International Health Facility Diversion Association, also known as IHFDA, Marsha Stanton, and the executive director of IHFDA, John Berkey. Welcome, Marsha and John.
Thank you. Thanks for having us.
Yes.
The background of each of you lends to a different perspective. So let's start there. Marsha, give us an overview of your professional background.
Well, I'm a nurse by training and spent a number of years in smaller hospitals in and around Salt Lake City, Utah. And in 1997, in 1986, my anesthesiology department came to me and said, let's start a pain program. I had no idea what a pain program was, and I'm not sure they did either, but it sounded good at the time. So we started with an acute service, which really managed all of the IV PCAs and epidurals within the hospitals. Shortly after that, people began to notice that we were having better outcomes with our recovering patients and things like that. So they allowed us to start treating the more chronic diseases. Subsequent to that, they also allowed us to start taking care of the palliation in many cases. So we ran the gambit from one end to the other. I was the national president of the American Society for Pain Management Nursing a number of years ago, and so have stayed very active in that area. When I joined the pharmaceutical industry in 1998, I very quickly ran into John Berkey, who became a dear friend. And we have, through the luxury of what monies I had in my education benefit, let's just say that, some of the companies have allowed me to do programs that John and I have felt were probably some of the best we've ever done in our lives. We worked with the recovering high schools for kids who had been really down and out and in the gutters. And now we're finishing their high school diplomas and doing things like that. So, you know, Terry, we've run the entire gamut. And my background primarily was in the pain area. But with John, I've learned very quickly, working with he and Kim New and other professionals in the area, that this is a two-sided problem, not just one side. And I had very well dedicated myself to the one side, but now I'm quickly becoming entrenched in both sides of the issue.
Yeah, that's great. I didn't realize I knew you had a large background in pain management, but it sounds like you guys were ahead of your time back in the 80s at that facility. That's fantastic. Doing a lot of good stuff. Yeah.
I think so. I think we really, I don't know that we were the ones that set the trend, but I'd like to believe that in many cases could be the issue. And I know that John and I, through our varied backgrounds, have been able to solve some of the problems that other people haven't been able to.
Yeah. And your work, I'd like to hear more on that at some point, your work with the high schoolers. That's a really neat thing. And with the pain management affecting patient outcomes, I mean, that's really what it's all about, right? We get a little caught up in the, decrease the opioid use, but really we have to remember that it's the outcomes that we're going for. So can we use less and get better outcomes? And, it's a win-win when it comes to the inpatient side, right?
Absolutely. Yeah. And I'll let John speak, but the thing that he and I have really and truly struggled with over the last few years is, of course, the CDC guidelines and all the rest of them that have come out. And now people are so fearful of giving what's appropriate as medications without really thinking about what they're doing to their patients.
Right. Very true. Very true. All right. Well, John, we have spoken before. I've interviewed before. You've shared your background, a little bit of your background and how IHFDA got started. So listeners, you can go back and listen to that if you want all those details. But do give us an overview of what your background is, because it's very different from Marsha's.
Yeah, I want to tell you that Marsha's being modest as usual. She was the main hammer with the high school kids. She found that program, and I was just blessed enough to be drug into it. So she's the consummate education person. And she didn't say that, but I'll say it. So anyway, my whole background, almost 50 years as law enforcement. I started out with Cincinnati Police. I was in internal affairs, and when you get out of internal affairs, they try and find a job that you like. And so this new pharmaceutical diversion job, nobody really knew what it was. They applied for a grant and got it. So we did that, and instantly I found out that there was a segment of that which had to do with diversion in hospitals and nursing homes. And so we began to spend quite a bit of time on that. That's how I kind of got started in that world. And we ended up, as I think I've told you, we ended up arresting a nurse about once a week. So, and this was before software. I mean, this was when people did things by hand. So anyway, I got out of that, went into Warren County, and we continued with it. And IHFDA was we were all involved in Natty, and Kim New and I decided to spin off, and we were doing this work for Natty, and decided we wanted to spin off and have an organization that dealt totally with this topic, and that's what we have with IHFDA. So that was started in 2015, and we just finished a great conference in which you, Terry, were one of the speakers and did a fabulous job, as you always do. So, but that's pretty much me. So I'm retired for the most part, probably about 80%. And by the way, having a knee replacement, I can identify with the pain management. That, you know, my orthopedic surgeon was very stingy. Unfortunately, I had an internal medicine guy who's my family doctor who wasn't. Otherwise, I would have been in a fair amount of pain. So I can identify with it personally just recently.
Interesting. Yes. So, and thank you. I appreciated the opportunity to present at the conference. Yes, when I saw John, he was in a wheelchair and then said that he had knee surgery, and I jokingly said, "Well, I hope you don't have your opioids," and found out that you had, I guess, quite a supply, right, from your internal medicine guy. But I didn't realize that your orthopedic surgeon had been stingy. So let's talk about that, if you don't mind, just a little bit. Did he talk to you about opioids and express to you that he wasn't going to give you much, or did he just give you a small amount, or how did that process with him work? I'm just curious.
It was amoxicillin initially, and 5 milligrams, and that was fine. And then what happens is he's part of a very big group, and so you don't deal with him anymore. You deal with his nurse or whoever. So I want to say they refilled it once. And then they lowered me down to, I can't remember what, tramadol. And you might as well be taking aspirin if you're, in my opinion, if you're going to take tramadol. So, and no, they really didn't. They just they have a set thing. It's like you get like one refill or two, whatever it was, and then you're done. I mean, they don't really talk to you to see, hey, what's your pain level and all that. And as you know, you have to be careful with those. But I've been totally off of them for some time. But without this other physician, I would have been in quite a bit of pain, I think.
So there wasn't a whole lot of education then, and talking. There wasn't a lot of partnering with you.
No,
on the discussion.
They don't know what my knowledge level is of all these drugs, you know. So I never told them anything. So they treated me probably like they do every other patient,
which probably isn't good.
No,
yeah.
They have a thing. It's one refill or two refills and you're done. You think somebody would talk to you, and I tried to explain that, but no, that's our policy. So anyway.
Interesting. All right. So we have a long way to go still.
We do.
Yes.
Absolutely.
All right.
And I don't mean to interject, Terry, but you know, the issue is from the education side, we thought we were doing well. And in actuality, we were doing well. You know, after the late 90s and up into the early 2000s, we really thought we were taking care of patients optimally. And then we realized that some people were taking it a step farther. I don't think any of the clinicians, and I say that lovingly because I know it includes physicians, nurse practitioners, doctors of nursing practice, doctors of pharmacy, and all the rest of us that are commingled in that whole area. No one was doing it out of spite or to create bigger problems in the world. Mm-hmm. It just is one of those situations where the confluence of all the issues came together at the same time. And yes, we had new medications, and yes, they were way more effective. And And yes, the patients got the medications. To John's point, he got 2 prescriptions. Well, if you go back 10 years, probably got 20 prescriptions. And he got prescriptions of 90 or 100 or 120. So we have not only taken a step backwards, unfortunately, but we've taken 2 or 3 steps backwards.
Yeah, yeah. And I really do think it all comes down to being educated on how the meds work, being educated on when is the right time for them and when is not, and being educated on the individual patient parameters, the risks that people are at for a substance abuse disorder. My risk might be higher than somebody else's, or vice versa, and partnering and having that real discussion to make sure that the needs are met and minimizing the risks, which, as we know, I mean, sometimes all it takes is one, right? And now we have a problem. But I think if we have those discussions up front, and maybe there would be less of a hesitation to ask for help if you've had those honest discussions with your physician, and then you realize, oh my gosh, I'm one of those. I've been exposed, and this is wonderful. I want more, right? And then maybe we could stop it sooner, because there wouldn't be that as much of that stigma and hesitation to say, oops, I think I had that high propensity for addiction and now I'm feeling it.
You made a comment a second ago about a relationship. The problem is there have not been the relationships that there probably needed to have been. In many cases, it is a prescriber coming in and saying, oh, okay, I'll give you this, and away they go out the door. When in fact, there needs to be far more interaction with the patient, not only intellectually or emotionally, but also physically, to know that it's the right thing to do at the right time.
Right, absolutely.
Terri, I wanted to tell you, you brought up a great point there. One of the things I tell friends that ask the question that I think is so important is look at your family history. If mom and dad are an alcoholic and a drug addicted, you need to be really, really careful about your use of these substances. And I don't think people understand that so much, that your propensity for addiction could go up incredibly depending on your family background. So, but no, I no counseling. Again, remember, this guy doesn't know I have any knowledge of anything in the way of drugs, and I got nothing. I got nothing. I didn't get something to say, take a little bit of food with your oxycodone. I didn't even get that. So anyway.
Nobody told you might be constipated.
No, they didn't. I knew that, but no, they did not.
Yeah, no, but I think, I think it's even worse that, you did have the experience. And so you had the people, you had the background, you had the information. Think about the people that don't have any of that, don't know to ask for any of that. It's not okay if they weren't told any of that, because they're completely ignorant with the whole thing. And so it's not a great example. And then to just, well, this is our policy, this is what we do. It's not a one size fits all. But I think too, I think that's a great message that you're telling people to be aware of family history, because I think the more that all of the lay people understand the propensity for addiction and how it affects us all differently, because I know I was baffled by that. It's, I've had it for dental procedures, and I don't even understand why it didn't even work for pain for me. So it's like, what do people see in this, right? So I'm very different than the person who takes it the first time, and it's a whole life that looks completely different. So the more people understand and then are not afraid to engage in that conversation with a physician. Look, this is my family history. I've never had it. I'm a little afraid. And then again, that open communication. If we could bring that into play, we actually might be able to fix this faster than restricting through CDC guidelines in terms of you can only prescribe this much and that's it. That's my policy, right? I'm going to give you this and that's it.
It's really a question physicians, before they prescribe controlled substances, should probably be asking their patient, what's your family history? It would be a typical thing to ask. And they say, well, do you have any history of drug abuse or alcohol abuse? And that can make you could add another warning to the taking of them. But
Well,
anyway,
and just remember that it isn't just physicians. It's the whole ball of wax. Anybody who has a prescription pad can write.
yes.
So we have to really understand that whether you be a physician or you be, well, in particular with physicians, if they're oncologists, perhaps they think very differently than a family physician does, or than someone who's in internal medicine or someone who's doing an orthopedic procedure. So it's not only the simple fact of educating people, it's educating them in their wheelhouse and what is it they really need. And would one term mean something different than another term? And do we need to be so cognizant of words that we embellish some points and diminish others? So I was part of the REMS program that the FDA put out a number of years ago, and I actually was the chair of the education group. And did we, in fact, do really, really good education? Yes, we did. And it was a combination of pharmaceutical companies and the FDA and the NIH and the HHS and SAMHSA. Everyone came together. So it was a very robust program. The problem is we were only allowed to charge or count one interaction. It takes more than one interaction to do this education and do it correctly, which is why John and I have tried on numerous occasions to do multiple programs in the same area.
Terri, I don't want to get you off track, but I gotta tell you about when I used to do a lot of these talks. I had a group of doctors in Milwaukee, and I just got done with my talk, which talked about drug abuse and all that. And this is a female physician stood up who was an oncologist and said to the group, "I never prescribe a Schedule II pain reliever." And I thought to myself, thank God I don't have cancer, and thank God that's my oncologist. I mean, to say that is and she was proud of it. And
she was proud of it. She was proud of it because she's not contributing. But at the same time, if ever there was a reason to bust out the C2s, that could be for those oncology patients. Interesting. Yeah, it is different. And you're right, Marsha, the education, we all learn differently. We hear some things, forget others. We have to hear it 2 and 3 times to finally get the message home. But this whole topic right here would be an interesting perspective for speakers for next year for IHFDA. If you have people that have some sort of a program in place, prescribers that have a program in place that do this and can walk us through if they've seen better outcomes, personalizing it. Would be kind of interesting. So on that note, how do you, with IHFDA, fabulous group, everybody that is not familiar with it, many of you listening probably are very familiar with it, but my goal is to capture those that aren't familiar with it and get them to your website to check it out, and then to your conferences to really learn. That's where I learned a lot of my stuff when I first got into the world of diversion, mitigation, and monitoring. But what kind of work and effort, what's your philosophy behind picking speakers and topics that can speak to those of us with more experience, but also engage and not go over the heads of those, not overwhelm those that are new into the space? Do you have any kind of thing that the board discusses in that area?
Absolutely. John, do you want to take it or do you want me to?
Well, let me start it off and then you
Okay.
can, because Marsha is the head of our education committee. We've been very fortunate, Terri. What we've done is we kind of opened it up for call for presentations. And that has brought in, like last year, I know we had far more people applying than we had room for, and some very good stuff. So, and Marsha leads that group along with Heidi McNeely, and we have the committee. And so we go through them, and it's not always easy. People get selected that it's really, they're really the cream of the crop, because we really have some great stuff that's submitted to us. And I think that's that's worked really well. That doesn't mean we don't reach out if we see somebody else or we think of a topic that maybe nobody covered. But I'll let Marsha go on. She's the nuts and bolts of this part.
Well, you're kind, but Terry, that's one of the reasons that we decided to initiate the fundamentals course this year, the one-day program to give people just a real taste of the various areas that they are going to be dealing with if they choose to come into this specialty or this therapeutic category, if you will. And so the 8-hour program gave them a nice flavor for what they would get through the rest of the conference. We hope to continue to do that on an ongoing basis because we're, on the one hand, where we know we have some of the real experts who are the folks that are doing this on a daily basis. We also know that there are going to be people that are placed in a position to start doing it and really have no idea how or what to do. And those are the people we'd like to really bring into the fold and help them understand that, number one, we're a friendly group. We don't really have cliques, and we don't really have people that are uncomfortable speaking to the newbies. We'd like to keep it an open group that really enjoys being together, sharing ideas and sharing their philosophies and their protocols. And as we grow, I think John can attest to the fact that we are becoming more sophisticated as an organization. We just got our feet wet a few years ago, and here we are now having a 3-day conference with 7 posters for research that people are doing. We hope to do more of that. So I think, when you say what's the philosophy is to grow, but to not grow faster than what we should grow, and to make sure that we're servicing and encouraging all of the different factions within the organization, whether it be those who are brand new or those who have 20 or 30 years in the business. So,
yeah, go ahead, John.
Well, it was discussed at our corporate meeting. We have the corporate sponsors. We have a breakfast for them. And one of the things that came out of that was, do we consider maybe a more than one track at a time? In other words, having something, a lot of places you go, the bigger facilities will have different tracks. And then that could be relegated to maybe the newbie person or whatever. So those are things I think that may happen down the road. I don't know that we're not ready for it yet, but we're very much in tune to your question, and that is, how do you handle both? And Marsha did it eloquently. The fundamentals was the first attempt at that, and we're going to keep that. I think we're going to tweak it in Chicago in May or March, whenever it is. But we're going to we want to keep it current, and so that when somebody goes in there, they're not looking at something that was 5 years old even. So hopefully that will help them. I don't know if you remember, if you were there, but we did a kind of a beginner's thing on one of the conferences. I don't remember which one, but we did it in the morning. We did 2 or 3 kind of beginner kind of things. But I like this better because I think it tends to cover the whole gamut of diversion. And so, people like yourself who are experienced probably wouldn't get much out of it. I wouldn't say much that you didn't already know. But when you look at it, and we didn't do it this year, I don't think, and maybe Marsha can tell me, but usually when we have groups like this and you ask them how many are new, almost half of the population in the crowd is new. It's their first one. Now that doesn't mean they're a newbie, but they probably are. They're not so sophisticated as a lot of people in the room. So we have to keep that in mind. So it's a balance all the time. Good.
Okay.
And Terri, I think, one of the things that is ultimately important to us as a board of directors, particularly now that we have started expanding our board of directors to include folks that may not have been part of the initiative when we began this organization. We would love to have a certification or a credential. We're not there yet, but the plan is at some point to have a national certification if we're able to do so, which would make it certainly more appealing, I think, to people who are not only new to the business, but to those who have been doing it for quite a while.
Right. Yeah, these are all good things. Yeah, I was going to ask you if you knew how many were new attendees and kind of new to the space. So over half, that's interesting. I don't remember that question being asked this year, and I think the fundamentals class, you're right. That's a great way to give them an overview so that they don't come in completely unprepared and like, what are they talking about? And it doesn't feel like it's as much over their head, because I think that is the risk that you take with conferences like this, is that those who have more experience, what are they going to get out of it, right, when they come, if there's not much? And I know in the past for me, it's been, even if it's something that I've heard and I know, sometimes it'll tickle something like, oh, I haven't looked at that in a while, right? Let me look to see if things have drifted from that. I better go back and look at that process. So that does take place, even if you're not learning something brand new. It's a reminder that you maybe should go back and look at something. But yeah, I did feel that the topics this year were broader and got a little bit deeper for those that needed some new content. So I thought that part was great. And your fundamentals class, you had a lot of people attending that did have experience, but I think they wanted to see what it was about. But moving forward, probably the new people, the newer people.
Right.
You brought up something about it tickles your. I had that experience with Dr. Talley, who came on our board a couple 3 years ago, and she's works for the state of Tennessee in bloodborne pathogens, and all the people that we encountered, I just never gave it a thought that each one of these people need to be potentially, if possible, tested for bloodborne pathogens. And she came on, and it was just like a light bulb went off after all the years they've done this, that we never did that. And so it's really nice having her on the board. It's nice, she presented this year, and for people to think about that, okay, you got everything settled, and now you're doing this. Well, what about, we may have 100 patients that have been subjected to hepatitis C or whatever. We don't know. And so anyway, that light bulb thing that you were talking about went off when Pam came on board.
Yeah, good point. All right, so the other thing that I did want to discuss was something that the two of you wanted to share and get out there for all of the listeners to hear, and that is surrounding the fentanyl deaths that we've been seeing and hearing about. So go ahead, and what is it that you two kind of realized, that the information that may need to get out there for everybody listening?
Well, John and I've had numerous conversations for years, talking about the issue of fentanyl and how the lay public is taking what information they're getting from the media, and they're, as you would expect they would, they're conveying that into their world. Well, the issue is the FDA approved fentanyl is not the fentanyl that is causing the real problem on the street. And John can talk more to that. But my concern is, for those of us who are clinicians, we understand that fentanyl, approved by the FDA in its various forms and fashions, is in micrograms. What's coming in from outside of the United States is undoubtedly in milligrams rather than micrograms. And so there's really no reason why, when someone has a tainted pill or capsule or whatever the case might be, that they aren't really in danger of overdose and death. And I think that's what both of us have been trying to accomplish, and trying to just spread the word as much as we can. We were fortunately asked to be involved in an article just recently during the IHFDA conference, where we expounded on that issue, that it's a very different molecule, not necessarily molecule, but a different molecule in the way that is being provided from those folks in Mexico, or those folks in China, or those folks who are making it in their bathtubs, whatever the case might be. But John has far more experience on that than I do. I just want to tell people, understand the truth, understand it's different, and help us convey that information to the general public?
You know, I can remember when I first got this, it's been a few years ago, and I was sitting at the table eating dinner with my wife, and a doctor came on the local news to talk about fentanyl abuse. And he had a packet of fentanyl patches. I mean, so not even injectable fentanyl. He had fentanyl patches, and he was talking about the fentanyl problem. Well, what would people in the audience think? Oh my gosh, these patches are the source of all. So I kind of went ballistic, to be honest with you, about it in my own house. And it is, as Marsha said, it's made in China. It's transported to Mexico, and it comes across the border and kills 100,000 people a year, roughly, our citizens. And I've seen recently on the ads when they'll talk about fentanyl, they'll go to a pharmaceutical package of fentanyl that they'll put on the screen. And it just, again, drives me, and I'm sure people like you guys, crazy. That's not the source. I can just about guarantee you that zero fentanyl from diversion in our hospitals and nursing homes go into this problem. As you guys know, the people that divert medication are addicts. They don't share their medication. They don't sell it. They keep it for their own addiction. And all this is a whole. And as Marsha said, when you think about measuring in micrograms and now getting something in milligrams, it's no wonder that people, and Mallinckrodt that is the typical. They manufacture what looks like a Mallinckrodt 5 milligram oxycodone tablet, and it's got quite a bit of fentanyl. And you take it, and if you're not an experienced drug abuser, there's a good chance you're going to die. And it's really sad. But yeah, I think that the whole message is it's not pharmaceutical fentanyl; it's clandestine fentanyl made in China coming through Mexico.
Yep, good point. Yeah, those of us in the healthcare space monitoring for diversion, fentanyl is very dangerous for our colleagues and those that are diverting, but completely separate from what we're hearing about on the news and all of those fentanyl deaths. I'll wrap it up by reading something from the United States Code Title 21, Chapter 13, Drug Abuse Prevention and Control. They state that 3 factors are driving the opioid aspect of this crisis in particular. The first one is the 1990s, a dramatic rise in opioid pain medication prescriptions. Second, heroin from Mexico has flooded the country. And third, the illicit manufacture of and illegal importation of fentanyl, an extremely deadly synthetic opioid, and its analogs and related compounds have been proliferated. Fentanyl is currently manufactured almost exclusively in China and is either shipped into the US or smuggled across the southern border by drug traffickers. Between 2013 and 2016, the amount of fentanyl seized by Customs and Border Protection at the border increased more than 200 times over. Dealers are increasingly lacing fentanyl into other drugs and pressing it into counterfeit opioid pills. Because fentanyl is lethal in even minuscule doses, this is an extremely deadly tactic, and it too often causes users to ingest a fatal amount unknowingly, which those of us in the clinical arena know that any amount for somebody that is not opioid tolerant is fatal, right? I mean, can be fatal. So that is in Title 21, and it is a different story and really scary. I think I read an article recently that a drug counselor in Arizona was quoted as saying, "There is no long-term illicit fentanyl users. They all die because it is so dangerous," right? So if ever there was a time to get the message out, just say no, right? We've got those campaigns. This is the time. I mean, what a scary, scary, scary world. I used to worry about my kids, high school, college. No, don't do it. Just say no. But it's even scarier now with all of this illicit fentanyl that is out there making things so extra dangerous.
Absolutely.
Yeah. All right. Well, I want to thank you two very much for spending this time with me. This is some great information, not only about IHFDA, but other things that you're doing and this message about what is going on out there with all of these deaths. So thank you very much for joining me.
thank you, Terry, for inviting us. And
Absolutely.
Thanks, Terry.
And those of you that are not familiar with IHFDA, I highly recommend it. Like Marsha said, it is a very open community. There are no cliques. Everyone is willing to share. If you're new, just strike up a conversation with somebody who has more experience, and they could probably talk to you for hours on things and give you suggestions. So it really is a great group.
Thank you. Thank you.
well,
Yeah.
thank you very
All right.
much.
Thank you.